Exercise is good for virtually all your risk factors. Lowers your blood pressure, raises your good cholesterol, your HDL, lowers your triglycerides, helps with body weight, helps with blood sugar. You want to know how many particles somebody has, how many bad particles you have. There's nothing like ApoB.
Dr. Paul Thompson is a professor in medicine and in cardiology and world-leading expert in the field of exercise and sport cardiology. Dr. Paul, thank you very much for coming here, and I'm very excited to talk to you.
Well, I'm honored that you would have me, and I want to compliment you on doing such a podcast, because I'm a big believer that if you want to improve medical care, one of the best ways you can do it is be a good teacher.
And thank you very much for coming. It's an honor for us to have you with us. I want to start by asking you about different types of exercise and how they impact heart functionality and structure. And I will start with endurance. How does endurance impact heart functionality and structure?
Well, it's two parts to that question. So let me divide them up. First of all, there's the good stuff about exercise, and then there are also some concerns, believe it or not, farther out. So let's start with the good stuff. It's pretty clear that aerobic or endurance exercise reduces the risk of heart disease. You know the story about if you get up to 10,000 steps per day, there's a big reduction in the risk of heart disease, and that's been shown repetitively. Now, one of the questions that we really have to be honest that we don't know the answer to is: do certain people select themselves to be more active? In other words, is it all just the activity, or is also something about the person? You know, there's this study in which they bred rats repetitively, and those that had the highest oxygen uptake, the best endurance, they bred them again. And as they got better, those rats actually had lower risk factors. So there's some really interesting interaction between not only the exercise itself, but the exercise, but who you are genetically, the exercise itself, and then the effect it has on risk factors. So aerobic exercises have been shown repetitively to reduce the risk of heart disease, given the disclaimer that we always wonder if it's something about the people that are willing to do that much exercise. Now, one of the areas that I have a big interest, because I was a competitive distance runner in my youth, qualified for the 1972 Olympic trials, not the team. I really wasn't very good, but the trials. So I've had a long interest in exercise at the highest level. And it's pretty clear that people, especially men, it's been mainly studied in men, who exercise, doing endurance exercise their whole life, they have a couple of things that happens to them. One is they have more coronary artery calcification than you would suspect. Okay, now that doesn't mean that they get more heart attacks. It doesn't mean they get more heart attacks. The increased calcium gives them the same risk as unactive people, even though the athletes live longer. But one of the things you need to know if you take care of a lot of athletes is that there is this increased risk of increased coronary calcification. The other thing is increased atrial fibrillation. You know, the bigger your atrium is, the more likely to have atrial fibrillation. And if you're a good endurance athlete, one of these lifelong endurance athletes we've talked about, that means that you've got good exercise tolerance. To have good exercise tolerance, you have to have a good stroke volume. You got to be able to push out a lot of blood. The engine has got to be able to supply the exercising muscle. If you've got a big stroke volume, you need a big left ventricle, but you also need a big right ventricle, and you also need a big left atrium, a right atrium. So the whole thing has to get big, and the bigger your left atrium, the more likely you are to get atrial fibrillation. So atrial fibrillation seems to be more common in endurance athletes. They have bigger aortas. Endurance athletes have a bigger aorta. That's been shown in a couple studies. And it's the other thing they have is that if this is your interventricular septum, let's say this is your right ventricle, where the right ventricle inserts right here into the interventricular septum, there's often fibrosis in these endurance athletes. Now, that's probably because, you know, the right ventricle has gotten bigger, and so there's tension on that insertion. So there's good from the exercise. Exercise does a lot for risk factors. all those sorts of good things. There's also a thing we need to be aware of, because I take care of a lot of very good endurance athletes. Very good endurance athletes have these anomalies. I'll give you an example. Amby Burfoot won the 1968 Boston Marathon. Very good runner. He actually ran 2 hours and 14 minutes, which is at one point, which is about 5 minutes and 4 seconds a mile. He came to me in 2013 with a coronary artery calcification score of 914. Now, he's done great. He's run every Boston Marathon since then. You know, he has this streak going since his first one that he won in 1968. But you just need to know that there is increased calcification in these endurance athletes. Now, I want to say one other thing before I leave that topic. Exercise is good for virtually all your risk factors. Lowers your blood pressure, raises your good cholesterol, your HDL, lowers your triglycerides, helps with body weight, helps with blood sugar. The interesting thing is you don't have to get into shape. You don't have to get into shape to get the benefits. What do I mean by that? We did a study where we had men exercise for 30 minutes, an hour, 2 hours, 3 hours. And what happened when you look at triglycerides? By the way, we measured triglycerides the next day. If you exercise for 30 minutes, the next day you had a little dip in triglycerides. An hour, a bigger dip. 2 hours, a bigger dip. 3 hours, a really big dip. In fact, we measured triglyceride levels in 12 men running the Newport Marathon way back in 1978, Newport, Rhode Island Marathon. Their triglycerides went from 96 the day before the race to 30 the day after the race. And then they were 60, and then they went back to 90 3 days later. So what I always tell, and the same thing happens with glucose. If you exercise today, your glucose gets a little better. Your insulin sensitivity gets a little better. So you don't have to get into shape to get some of these beneficial effects of exercise. Now, getting into shape helps. Why does getting into shape help? Because if you're in great shape, you can do more exercise, so you can get a bigger, what we call an acute effect. So, you know, I can go on I can bore you to death on this because it's such a big interest of mine and something I've studied all my life. But overall, the benefits of exercise are good. But if you take care of people who do a lot of exercise, you also have to know the other side of the coin.
Do you find the negative impact happens more with certain type of intensity, high intensity versus low to medium intensity, and also duration?
That's a great question. So it seems to be more lifelong exercise. Now, most of our studies, and I do this in combination with a great group in Nijmegen in the Netherlands, led by a guy named Thijs IJsvogels. But most of our reviews and looks at that, it looks like intensity over lifetime is the biggest factor. But other studies have shown it's simply the amount of exercise, the total amount of exercise you've done during your lifetime. So that's a bit of a debate. We're not really certain. We're also not certain of the mechanism. I can tell you what I think the mechanism is, but I may be totally wrong. You know, the coronary arteries, and I always tell patients that coronary stands for a crown, you know, because to the early anatomists, the coronary arteries sitting on the heart look like a crown. If your heart gets bigger from exercise, those coronary arteries, which sit on the outside, every time the heart contracts, they're basically going along for the ride, right? They have to twist and turn as the heart twists and turns. So if your heart gets bigger, they have to twist and turn more. So why does that matter? Where do you deposit atherosclerosis? You deposit cholesterol. You make atherosclerosis of places of turbulence, you know, like the carotid siphons, the bifurcation of the aorta, the femorals, you know, because we're all bent. Many of us sit most of the day, so that's a bending point. I think that, a lot of people think the coronary arteries get atherosclerosis oftentimes before the rest of the body, or at least symptomatic before the rest of the body, because those coronary arteries are twisting and turning. Now, if your heart's bigger, they have to move farther. Those coronary arteries have to move farther, and perhaps they create more turbulence. Now, look, that's my theory. It's very hard to prove. And my wife says that I'm often wrong. I'm just never in doubt. So That's what I think, but I'm not sure, obviously.
In your opinion, as a leading cardiologist and expert in exercise cardiology, what type of exercise and intensity and duration is it best to maximize benefit with the lowest risk?
You know, the exercise that you're going to get, the best exercise for an individual is what they want to do, is what they're interested in doing. Now, if you ask, because, you know, it's like pills. Pills don't work in the bottle, you know. Exercise doesn't work. When you're thinking about doing it, you actually have to do it. So, you know, people ask me what's the best exercise, and I tell them what do they like to do. Some people like to bicycle, so bicycling are good. I think it's hard to beat walking. Walking is a great exercise, you know, and the current recommendations, if you did about 150 minutes per week of fairly brisk walking, you don't want to stroll, you know, it's not da, 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 da. It's not the old song, The Stroll. You got to kind of move along. But if you did that a week, that's where you seem to get the most benefit. You know, when you go to, here's no exercise up here. When you start a little bit of exercise, there's a fairly steep decrease in the risk of heart disease. And then it starts to plateau out. And in some studies, there's actually an increase over here, which we've talked about before, maybe some side effects. But you get the most from going from almost nothing to something. Now, 150 minutes a day is not very much. You divide by 7, it's about 22 minutes a day. So I recommend that people do, if they ask my advice about what to do, suggest that they do walking briskly for at least 22 minutes a day. And that's a great exercise. So one other thing about walking is, you know, if you're overweight, you use more calories walking than a thin person like I do. So I always tell people, I pat their tummy and I say, we're going to use that lemon to make lemonade. Because when you walk a mile, you burn more calories than when I walk a mile. So let's get you walking. Now, when you're on a bicycle, the weight is supported. So a heavy person doesn't pay as much energy-wise until they're riding uphill. And the same with swimming, you know, you're supported by the water. So I'm a big walking fan for most patients.
By the way, that risk where someone starts to exercise and the risk of heart disease drop, then plateau, also is there for stroke and cancer and death and many other diseases as well.
Get the most benefit at very low doses of exercise. I'm going to change the subject a little bit. I'm going to talk about statins. Believe it or not, you get the most benefit from a statin per milligram of drug at very low doses.
Yeah.
Okay. And this is called, I call it I don't call it, well, I didn't make it up, but it's called the statin rule of 6. So let's say that let's say my LDL is 200. And you, as a good doctor, put me on pravastatin, 20 milligrams. Well, I'll get about a 25% reduction. So I went from 200 to 150. Oh, that's not enough, Dr. Thompson. We got to lower your cholesterol more. I'm going to double the dose. So when you double the dose of pravastatin from 20 to 40, you don't get another 25% reduction. You only get a 6% reduction. And it's even worse when you get to the high doses of the drugs. For example, if you go from 40 of atorvastatin to 80, you only get about a 4% reduction. If you go from 20 of rosuvastatin to 40, you only get about a 3% reduction. We've shown in one of our studies, really, I don't remember, maybe 2013, I took a bunch of patients from my clinic who had muscle aching, didn't want to take a statin. We put them on 5 milligrams of rosuvastatin Monday and Thursday, okay? They got a 27% reduction from 5 milligrams Monday and Thursday. Now, why did that happen? Number one, you get the most reduction per milligram of drug at very low levels. And number two, rosuvastatin, atorvastatin, they have long half-lives. And that long half-life allows you to use them intermittently. So, you know, a lot of people need statins, but don't want to take them. And so I often will use low doses like that. Now, I know I got off the exercise topic, but the same thing with exercise. You get a lot from a little. You don't have to become, you know, a marathoner to get benefits. A little bit. The key point is doing a little bit every day so you get that acute effect over and over and over again.
Is it that lower intensity or medium intensity has lower risk for all of the complication, arrhythmias, and the enlargement of the ventricle and the high calcium scoring.
Yes, just about everybody believes that low and moderate intensities are safer than high intensity exercise, than like the HIIT stuff, high intensity, HIT, high intensity exercise. All of us hit HITT, high intensity training. Yeah, we do. But I want to also emphasize that the risks of exercise are not great. We did a study way back in 1982 where we collect everybody who dropped dead in the state of Rhode Island. Rhode Island is the smallest American state. And we found among healthy people, there was only one death per year for about every 15,000 joggers. David Siskovic did a study similarly. Mine was published in JAMA. His was published in the New England Journal of Medicine. He found one death in every 18,000, 15,000. The risk isn't very high, one per year. But the other thing is, I think the risk now is even lower. Why do I think the risk is lower? Because so many people have their blood pressure, at least in the United States, have their blood pressure better controlled, their cholesterol's better controlled. So I think the overall risk goes down. Now, how do you reduce the risk? Do you do exercise tests? Well, I argue against exercise tests as a screening. Now, why is that? Because in order to have a positive exercise test, you have to have a lesion that's critically narrowed, right? If you have a lesion that's critically narrowed and you have no symptoms, that means the heart is tolerating it, probably because it's developed collaterals. Exercise tests don't predict who's going to get a heart attack very well. They don't predict who's going to get sudden death very well. What do they predict? Who's going to get angina? Because to have a positive test, you've already got to have a pretty narrowed artery. What type of lesion causes sudden death? The lesion that goes from being not very narrowed, just atherosclerosis, to getting a crack in the plaque and getting an acute blood clot suddenly, okay? That blocks off flow before the body has a chance to develop any collaterals or any adjustment to that. I tell patients that it's like, I drive to work on something we call Route 91, okay, near my house. I drive to the hospital on Route 91. So if I'm up in the morning and I'm shaving and I hear that Route 91 has got a big traffic accident, I'm not late for work. I take a collateral artery into the city. And the heart does the same thing. If it knows it's got a narrowing, it develops collateral arteries around it. I get in trouble if I'm driving along in 91 and a tractor trailer truck turns over, just in front of me. Then I'm going to be stuck there all day. You get the point.
So how would you recommend to screen the vascular disease early on, other than the treadmill test?
Screening isn't a very good strategy for most cardiovasculars. I know everybody likes it. It's a good way I call it the cash register for cardiologists, because it's a good way to get, do a test and stuff like that. But the best way to screen is to make sure that patients know what the symptoms are. So many people ignore their discomforts that come on with, especially exercises, because they've grown up with this idea that exercise prevents it from them getting heart disease. So they start to get, heartburn, or they start to get upper belly pain, or they start to get pain in their jaw when they're jogging or exercising. And, I always, the most important thing is that if you see athletes is to let them know that if they have new symptoms, decrease in exercise tolerance or whatever, let me know, because that's when the stress test or all these other tests become very useful. But the most important thing is to prevent the whole process before you get there. Yes. Now, with people who want to start an exercise program, if they want an exercise test, I'll do it, because sometimes people will start an exercise program because they've worried. They have this new symptom that they're not telling anybody about, but they're worried about it a little bit. So when somebody says they want to start an exercise program, what do I suggest? I say, well, why do you want to start? You got any new symptoms? Is anything going on? What's going on? Why do you want to start? And then the most important thing when someone wants to start a new exercise program is to tell them to start low and progress slowly. Start with a little bit and progress slowly. And if you get any symptoms while you're doing it, give me a holler. We'll check them out.
Chest pain can be tricky, and a lot of time with exercise, they can have burn in the stomach, muscle pain.
Well, the first thing I don't like to use the word pain, at least in English,
Mhm.
because many patients don't refer to it as pain. They refer to it as a discomfort. You
Yes.
know, the classic Herb Levine sign is this gripping after the famous Boston cardiologist Herbert Levine, not Herbert Levine, Sam Levine. Herbert Levine was his son. Herbert Levine was one of my professors when I trained at
Yes.
Tufts. But Sam Levine was the Harvard cardiologist, and he described Levine's sign, which is just, well, I don't have a, do you have any pain? No, I got this discomfort in my chest. It's kind of a tightening. So, I think one of the most important things is to let patients know that anything from their earlobes to their belly button that comes on with exercise can be a problem. And, patients, I'll show you a little funny thing that I do with patients. So I take my finger, right, and I draw a little face. I draw a little face. So I don't know if you can see that, but there's the little face, and
Yeah.
there are the two eyes, okay? And what I tell them is that, look, when you're an embryo, you're all curved up like that. And right in this area here is where when you unravel, sorry, this area here, when you unravel your jaw, your top of your stomach, what do we call the top of the stomach? The cardia, huh? Get the point? Your esophagus and your heart all come from this same dermatome area. So you can feel discomfort in your shoulders, either arms. A lot of patients, a lot of doctors don't know that. So, I always tell my patients who are starting an exercise program, look, anything that comes on, earlobes to belly button, that comes on with exercise when you're starting this new program, you be sure to let me know. I want to know about it. And don't wait a week or two. Give me a call. We'll get you in. We'll take a look and see what's going on.
What kind of testing would you usually do if someone has chest pain? Would you go for CT angio, or how would you deal with it?
I almost always start with a good old regular exercise stress test. Now, let me give you the thing that bugs me. A lot of all the studies that have compared the good old regular stress test with anything else, nuclear, whatever, um, they use only the ST segment changes. Now, I look at this, when I look at a stress test, I divide it into the internal workload and the external workload. What's the external workload? The external workload is how far did that patient go on the treadmill? Now, remember, it's not a hand grip exercise, so they can't be holding on for dear life, which drives me nuts when I go down the stress test. But if a person can go a long way on the treadmill, that means that they've got a stroke volume that's good. The primary determinant of how well you do exercise wise is whether you got a good squeeze, you got a good stroke volume. So that's the external workload, and that tells me, oh, if the person went a long way, they probably got a pretty good heart, a heart that can take a licking and keep on ticking, like the old Timex commercial from the 1950s. Then the other thing I look at, that's the external workload. How much work did they do on the environment? I look at the internal workload. What's that? The heart rate. If they got to a high heart rate, even if they've got a narrowing, it can't be very tight because those coronary arteries are the fuel line to the heart. So if I'm just evaluating someone, first of all, the history. I get so much out of a history with anybody. But then if I'm, then a regular old exercise stress test will give you a lot of sense. I don't necessarily need to know if they've got atherosclerosis. I need to know if the atherosclerosis is causing their present symptom. That's especially true in the emergency room. When someone comes into the emergency room, in our place, they often hang around a long time to get a special test. If you put that person on a treadmill, they get to a good workload and a good heart rate, and they didn't get the discomfort, they may have some disease there, right? But it's unlikely that that's what brought them in, because they should get the discomfort that brought them in. Now,
Mhm.
I got a plug to make, Dr. Ferris. I write a blog that's free. Okay, I say it's free and worth every nickel, but it's free, and it's called 500 Rules of Cardiology. It's on Substack, and a lot of these things that we're talking today about, the exercise stress test and the internal external workload. I've written about those things on the blog if people are interested. It's free, as I mentioned. I do it really for educational purposes.
Yes, I will link that. I will link it in the here and in the description as well.
It's great.
What?
It's not in Arabic yet. It's not in Arabic.
Yes, maybe soon. And what are your thoughts about strength training and how does it impact the heart functionality and structure?
So there's a review on that's looked at strength training and its heart changes in heart function. So that clearly has some benefit, but I don't think the benefit has been documented to be as good as the benefits from aerobic exercise training. The effects on blood pressure may be better, may be stronger, because when you do that straining during exercise, you kind of innervate your carotid sensors, and so that may help with blood pressure control and stuff like that. There is a lot of now aerobic exercise is very good for blood pressure. Let's talk about that.
Yeah.
Linda Pescatello, who's a very well-known exercise physiologist at the University of Connecticut, and of course I'm in Connecticut, she showed that if you do aerobic exercise for like 30 minutes in the morning at about close to your lactate threshold, that your blood pressure is lower for the rest of the day. Because when you exercise like that in the morning, you do raise your blood pressure. She thinks, can't prove, but she thinks that the baroreceptors in the neck are reset for the rest of the day. So believe it or not, working out in the morning gives you about a 5 millimeter reduction in systolic blood pressure the rest of the day. When you strain doing weightlifting, okay, that also increases pressure in the baroreceptors and may reset your blood pressure to be a little bit lower. But the data is much stronger for aerobic exercise. But the thing I push weight training, strength training for patients is two things. Number one is people can outlive their muscles. If we lower your cholesterol, if we take care of your blood pressure, we take care of your glucose, you don't get any of the things that kill people from those things, you're going to live a long time. You could outlive your strength and wind up in a nursing home or assisted living simply because you can't climb the stairs, et cetera. The other thing, and I'm a big pusher of strength training, is, we're using cardiologists like myself in prevention are using a lot of these GLP-1 agonists. And, the thing that happens when you lose weight is you also lose muscle. Now, some of the studies suggest that the muscle tone is still good. I'm a little skeptical. So I encourage patients who are on GLP-1 agonists to make sure that they get to a gym or get to do some weightlifting so they don't lose their skeletal muscle.
I want to ask you about hypertension during exercise and the spike of blood pressure during exercise. Some individuals have very high spike in blood pressure during exercise, 180, 200, 220, and even higher. Is that harmful and would cause some endothelial damage or some arterial damage, or is it just physiological? And would you recommend these individuals against high intensity training?
I don't recommend those people against high intensity training in general, because we've seen some very high blood pressures in some very good athletes. But what it does tell you is that there's an inability in that individual to vasodilate. When you exercise, you should be able to open your blood vessels. If you don't open your blood vessels very well, you're going to get systolic hypertension during exercise. Now, there's no studies that I'm aware of, there may be, but I'm not aware of them, that show what the prognosis of that is for an individual. But what it is, that whether that high blood pressure during exercise is going to give them a problem, like a stroke or a dissection or stuff like that. But what we do know is that high blood pressure during exercise is a warning that they're going to get more sustained blood pressure later on. So if I see someone that has real hypertension during exercise, I don't necessarily treat that. But if their resting blood pressure is borderline or on the higher side, then I do treat it, because that high blood pressure during exercise is showing that they can't vasodilate well enough to take the stroke volume, and they may get into some trouble. Some very highly successful young endurance athletes get very high blood pressures during exercise. Why? Because these are world-class athletes and they've got enormous stroke volumes, right? and you can only vasodilate so much. So you've got to remember who you're dealing with. If you're dealing with somebody who gets systolic hypertension during exercise at relatively low levels of exercise, relatively low levels of exercise means that they didn't have a very big stroke volume. That's much more concern than that systolic blood pressure you see during maximal exercise in one of these really highly well-trained endurance athletes.
I know you said that there is not a study that will that shows what is the outcome or prognosis, but in your opinion and from your experience, would you say that might have a negative impact over time, that someone every time he exercises, the blood pressure just shoots up?
Yes, I don't know the answer to that, but I do. But my suspicion, that's not a good thing. That basically means that their blood vessels are stiff, right? That they don't vasodilate very much. You know, we often see, now we see it in two groups. We see it in those young athletes who are really, you know, top level. And so they get a big stroke volume during exercise. Then you also see it in older athletes. And I think in the older athletes, it's simply a marker that they don't have as good a vasodilating capacity.
At what threshold or at what level would you start to get concerned that this spike in blood pressure is too high, 160, 180, or?
Oh no, much higher. So kind of start paying attention at 200, get concerned 210, 220. Yeah, but there are, and again, nothing is in isolation. So what you do with that 180 or 200 or whatever depends on who that person is. If that's achieved in somebody who's really quite good and very fit, less concerned than in somebody who's not very good.
Yes, and we're talking about the systolic blood pressure ones, right?
I don't pay a whole lot of attention to the diastolic blood pressures unless they're recorded automatically during exercise, because they're just all over the place. So really, you're paying, and I don't remember what the age is, but once you get over about 40, the predictor of problems is really your systolic blood pressure. I always think of it as that's the weight that the heart is lifting. That's the weight that it has to push up to get the blood out. And so that's what's going to lead to cardiac hypertrophy and problems. And also the systolic blood pressure, what's going to possibly, induce an aortic tear or rip or whatever.
What does an individual like this do if he has a spike in his blood pressure? Should he avoid maybe high intensity completely and just stick to low intensity and try over time, maybe the low intensity will lower his blood pressure over time? Or what would you recommend?
So it's very rare that I see somebody that's doing a lot of high intensity exercise who gets markedly hypertensive during exercise. But what do I do? If I'm really concerned about that, I use, angiotensin receptor blockers. I mean, if I'm concerned enough to restrict somebody's exercise, which I don't think I've ever done in my lifetime, then I'm going to think about treating them. And I'll bet you dimes to dollars that they don't have really good resting blood pressure if they get markedly hypertensive during exercise. Where that most of us historically used 140 systolic as the number we paid attention to. But studies have shown that you do better. The sprint studies show that you do better if your blood pressure is under 125. So when somebody has a lot of hypertension during exercise, I look for an excuse to treat them. Why? I don't think the high blood pressure is a good thing during exercise, right? And they're going to get hypertensive at some point, or at least they're more likely to get hypertensive at some point. So, I look for an excuse to treat them. Now, if we're talking about athletes, because we are right at this point, if we're talking about athletes, I sell them ACEs and ARBs on the idea that vasodilatation during exercise may be beneficial. Now, I can't prove that to them, but.
Do you have a specific or favorite ARBs or ACE that you choose? Some of them work longer and some of them are short. Would you choose?
I'm a bit of a lorcertan fan. Now, yes. I can't give you a lot of, it's just that it's a drug I use and feel comfortable with. And so I use the lorcertan a lot. I'm an ARB fan. I'm not a big ACE fan because I think we underestimate the number of people who get coughing with ACEs. I can't tell you the number of patients whose coughs I have cured by switching them from an ACE to an ARB.
There are some studies that isometric exercise improves blood pressure. What are your thoughts about that?
So I always get a little nervous when somebody says there are some studies. And First of all, it's a good question, but you can find anything you want to find in the medical literature.
Yes.
And I think it's getting worse because, at least in the United States, because it used to be there was the New England Journal of Medicine.
Mhm.
Now there's like 4 or 5 different New England Journal of Medicines. There used to be the Journal of the American College of Cardiology. Now there's the Journal of American Cardiology, Heart Failure, Electrophysiology, Case Reports,
Yes.
Genetics. I mean, okay, now you've got to fill those pages.
Mm.
I do a lot of reviewing for journal articles, and there are frequently times where I'll say, look, this journal article is not very good. I would publish it only if you were desperate, and it gets published. So I actually, it's something I'm going to write about in my blog sometime. I think there is becoming a pollution of the medical literature. Now, that makes it harder for you clinicians out there, because what you're often provided is just a summary by some, drug pharmaceutical company supported paper that just reads the headlines and summarizes it for you. So you can find anything you want in the medical literature. Now let's get back to your question. It makes sense to me that isometric exercise would lower your blood pressure. Why? Because when you're in that strain phase, you raise your systolic blood pressure. I can theorize, that would reset your baroreceptors to have a little bit of a lower pressure. So it makes sense to me. I'm not an expert in that literature. You should get my buddy Linda Pescatello to talk about exercise and blood pressure, because she's one of the world's experts. I am not. So, I don't want to make up too many answers here.
Blood pressure by its nature fluctuates, and for some people more than others. If someone has labile hypertension, that it goes normal, let's say it's normal at home and even below 120 systolic and below 80 diastolic, but at times it would go very high depending on what they're doing during the day and how stressed they are and how active they are, and it would also spike during exercise. What would you do in these cases?
But I would consider myself more of an expert in exercise, lipids, those sorts of things. But my understanding of that literature is that the best thing to do is a 24-hour blood pressure monitor and use that to guide your therapy. Now, I must tell you that I'm always suspicious about so-called white coat hypertension. I have a lot of patients that come into my office and they're hypertensive and they're in the office, but they're not hypertensive at home when they measure it at home, and they don't look hypertensive when you do a monitor on them. But life, at least in the United States, I'm sure where you are
Everywhere.
is stressful. And so if being in the office with me makes you stressful, I wonder how many other times during the day your blood pressure is high as well. Also, all our old studies were based on not 24-hour blood pressure monitors, but they were based on measuring people's blood pressures in clinic visits. So I follow the literature and what the patient wants. I don't push the patients to be treated in those instances when they have episodic hypertension. But I do talk to them about it. And if some people are more willing to be treated than not, and in those people I may do low dose of, an ARB or something. I may, but not usually. I would like people to follow perfect diets. I would like people to exercise every day, but most people don't. So I don't view medicine as a morality issue. Sure, you should exercise, but if you don't and you've got risk factors, I'm going to treat them with drugs, because that's what I do.
A lot of athletes and runners, they would have slow heart rate and bradycardia. When do you say that that's physiological change, and when do you get consent that is pathological change?
The history is the best example. If they're asymptomatic and have bradycardia, you expect bradycardia in athletes. Now, there are several, and I wrote the editorial on it, so I know about it. There's now a study out of Scandinavia that looked at heart rates in lifelong endurance athletes. And those that had slow heart rates were more likely to wind up with pacemakers. Now, the thing we don't know for sure from those studies, did they wind up with pacemakers because the patient felt bad or the doctor felt bad? Because, it's hard to watch these people who have, slow heart rates. But It's with athletes, it's almost always physiologic. The slow heart rate is almost always physiologic. It doesn't usually cause symptoms, but occasionally it does. So you have to pay attention to these people. And if they have symptoms with their slow heart rate or marked pauses and whatever, then you have to proceed with a pacemaker. And I do this with the advice of my electrophysiology colleagues.
If the heart rate gets slower, would that make it more likely that it's pathological? For example, if it goes below 50 beats per minute, or it doesn't necessarily matter?
Yeah, I'm trying to remember the guy who won the 1936 5,000 meters. He was an Australian. I know he's a New Zealander. Anyway, he had a resting heart rate of 30 beats per minute.
Oh, that's very low.
So yeah, so we've seen a lot of athletes with very low heart rates, as long as they're asymptomatic and they increase normally with exercise. Now, if they have symptoms, you've got to be much more. Jack Lovelock was his name. Jack Lovelock, who won the 1936 5,000 meters, had a very slow heart rate. In fact, he was on the BBC. The BBC had him on the radio in the 30s. It recorded his heart rate on the radio because it was so remarkable. People were so surprised. But so Jack had a very slow heart rate, was asymptomatic. But I'll tell you an interesting story. He became a physician and worked in New York City. And one day he didn't feel well at work. And so he was going home and he fell onto the subway tracks and was killed, believe it or not. So I've always wondered if his very slow heart rate contributed to his, passing out, falling on the subway tracks when he was older. So the bradycardia in athletes is physiological. But recent studies have suggested that they're more likely to wind up with pacemakers than other people.
Someone is very active and doing a lot of high intensity and his heart rate starts to slow down quite significantly. Would you advise them to reduce the intensity of the training or the duration, or that's not something you would do?
It's a situation I haven't dealt with, to tell you the truth, because if it's going progressively lower, that's a normal physiologic response. So I would never, what does it mean? It means that their stroke volume is getting bigger. And if their stroke volume is getting bigger, that's a good thing. You also know that slow heart rates are associated with increased longevity.
Yes.
And slow heart rates are associated with less atherosclerosis, because there are less beats, so there's less turbulence.
Yes.
But no, I don't know. I wouldn't know what to do with that instance. If I saw somebody's heart rate was getting slower, it may be that they're getting in better shape. A lot of athletes use decreasing their heart rate as a sign that their training, program is working, and it's true. It means the stroke volume has gotten bigger.
In athletes, especially during exercise testing, we see a lot of premature ectopic beats and ventricular ectopic beats. What are your thoughts about ectopic beats, especially in an asymptomatic patient and healthy?
Treat them with benign neglect. I don't do anything about them unless they're very frequent or they're bothersome. Now, that may not always be the case. In other words, there could be other underlying conditions, but at the present time, I don't do a lot about them unless they're symptomatic or bother the patient. I'm not adverse, if you have a patient that you're concerned about, to getting an MRI. I do think at some time we're going to figure out that some of these people have little areas of fibrosis. You don't want to miss something in an athlete getting older who's got amyloidosis or something else coming on. But generally, I treat asymptomatic extra beats with neglect.
What's your opinion about smartwatches and wearable devices that monitors heart rate and track them on performance? Do you have any thoughts on those devices?
No, I don't have strong thoughts on them. If I have a patient who has, no, I don't have strong thoughts one way or the other. I'm not a gadgeteer, so I have to get somebody else to comment on it.
Have done a lot of work on cholesterol metabolism, and I want to get your thoughts specifically on ApoB and lipoprotein A.
Okay, I got two thoughts.
Yes.
Number one, what your audience needs to know is that every bad particle has one ApoB. So here's your quiz. How many ApoB on an LDL particle?
One.
One.
Yes.
How many ApoB on a VLDL particle? One. On a chylomicron, 1. On a chylomicron remnant, 1. So if you want to know how many particles somebody has, how many bad particles you have, there's nothing like ApoB. It tells you don't have to get any fancy tests. You got a cheap little old ApoB, and it gives you an idea of how many bad particles you have. Now, a lot of people use non-HDL cholesterol to do this. Now, here's the problem. There is a very strong relationship between ApoB and non-HDL cholesterol. The relationship is a curve that looks like that. The correlation is like 0.97, but that's a population. That's a population. If you look along this curve, here's an ApoB way up here with a non-HDL down here. In other words, there are people all over this line, but the line for the population is good. So I like to measure ApoB not using any surrogate measure. So ApoB is probably it is a better predictor of what's going to go on with somebody than even LDL. But all the guidelines are based on LDL. It's unlikely those guidelines are going to change. So I always get an ApoB to give me a sense. I don't always get an ApoB. I always get an LDL. And if I have questions about things, so want to question particles number or something like that, I get an ApoB. The next deal is lipoprotein A. Lipoprotein A is a big deal. Now, this is not apolipoprotein A, the thing that's on HDL. This is little a, or lipoprotein A. It changes any cholesterol you have. So if you have a high cholesterol and a very low lipoprotein A, you're much better off than somebody with a high cholesterol and a high lipoprotein A. Now, I say you should measure lipoprotein A so that you don't give false reassurance. What do I mean by that? Somebody comes into me and says, my father had a heart attack at 44 and I'm really worried. And here are my cholesterol levels. And their cholesterol levels are good. Before I say, forget about it, I always measure that lipoprotein little a. And so many times the person has a very high lipoprotein little a. And so I will treat them aggressively. Now, we don't have good ways to treat lipoprotein little a at present. There are a couple things that raise lipoprotein A. One is hypothyroidism. If you're hypothyroid, your lipoprotein A goes up. When you go through estrogen, your lipoprotein A goes up a little bit because estrogen lowers it. Testosterone lowers it. We were one of the first, I think, to report that. So there are some things that lower it, but there aren't many things that do it. Niacin will lower it, but I'm probably the only one that uses niacin much. PCSK9 drugs will lower it, and drugs are being developed to treat lipoprotein A alone. Now, one of my 500 rules of cardiology is when you can't treat the risk factor, treat the risk. So we can't treat lipoprotein A directly. Niacin would do it a little bit. PCSK9 inhibitors would do it a little bit. So what do? I treat the LDL much more aggressively because when you can't treat the risk factor, treat the risk. And what do we know about statins? They reduce risk. And let's think about it. Statins reduce risk in people with diabetes. The ASCOT trial, it reduced risk in people with diabetes. But statins increase the risk of getting diabetes. But if you got diabetes, they reduce your risk. Statins reduce the risk of hypertension. They don't treat hypertension, they reduce the risk. So statins can be used to reduce the risk even when you can't treat the risk factor.
In your opinion, what is an optimal level for ApoB?
I don't know the optimal level. What I usually search for is I use the LDL recommended levels and then add 8 to 10 points to that. So if your LDL goal, and of course I'm doing milligrams per milliliter. I'm not doing if your LDL goal was 55, I would shoot for an ApoB of 65 or thereabouts.
So you don't check ApoB by itself. You always compare it with
Not usually.
cholesterol.
Not usually. I usually go off the LDL. Now, if somebody says, I want to know how many particles I've got, I read about particles, they're the most important. I said, good, we're going to measure ApoB. Or if someone's triglycerides are high, or if you can make a good argument for measuring ApoB all the time. And my friend Alan Schneiderman in
Yes.
Canada, he's one of the world's experts in ApoB. He really thinks it should replace LDL cholesterol. I don't think it will, because we've driven the whole idea of LDL into everybody's heads so deeply. But you can make a good argument for measuring ApoB and using that both to get a sense of what your particle number is, and also just as a better marker than LDL. But I don't do it all the time. My goal is, I usually shoot for 10 over what the recommended LDL goal is, 8 to 10 over what the recommended LDL goal is.
Mhm. And what about lipoprotein A? When do you start to get concerned that it's too high or above normal?
Well, yeah, as you know, and I always have to remember what I'm measuring at, but the normal measurement in our institution is under 75, and the risk takes, once you get over these normal levels, the risk goes up. So I can't give you an absolute level. It has to fit in with everything else. But I think lipoprotein A is going to be a major factor in how we deal with people.
Statin elevates the lipoprotein A a bit.
Yeah,
What are your thoughts
been
on that?
been an argument back and forth on that, depending on studies. My overall argument is that we don't have much to do to treat the lipoprotein A. The risk, in my opinion, I think we can find plenty of literature to support that, is lower with the risk of apolipoprotein A is lower when you get the LDL down. So that's what I do. I get the LDL as low as I can. And sometimes if it's really high, I may consider adding a PCSK9 inhibitor. But and then the other thing I often do is, with people who have a high lipoprotein A, is I put them on aspirin, because we don't know the mechanism by which LPA increases risk. I mean, it carries cholesterol, it carries phospholipids, so it's inflammatory, and it also increases clotting. So I put most of the patients that I have an elevated lipoprotein A, I put them on low dose aspirin if they're not on an anticoagulant.
What are your thoughts for statin as a primary prevention in someone who's athletic and borderline elevated LDL level or ApoB levels?
It depends on that person's overall picture. It depends. So we study, there's a lot of concern about what statins do to skeletal muscle. Now, we've studied that extensively. That's where a lot of our National Institute of Health funding came from. And we find that the incidence of real documentable myalgia, now not bad enough that the people wanted to stop the drug, but that they had symptoms, is about 5%. So we did a study called the STOMP study. And what we did is we took 420 men and women, and we randomized them to either 80 milligrams of atorvastatin or placebo, double blind. We didn't know what they were on. We measured exercise performance. We measured muscle strength. We measured symptoms. And we would call them every 2 weeks and ask them if they had any muscle complaints. If they had muscle complaints, we would stop whatever they were on, placebo or drug, for 2 weeks to see if the symptoms went away. If the symptoms went away, we put them back on the drug to see if the symptoms came back. And if the symptoms came back after all that, we called them statin myalgic. Now, what we found that 10%, well, really 9% of the people on the statins, on the 80 milligrams of Tortin, about 9% of them got symptoms. About 5% of the people on placebo got symptoms that went away when we stopped the placebo, that came back when we started the placebo. So we think the true incidence of muscle aching, now this was only a 6-month study, is about 5%.
Yeah.
Right around that number. So it happens. Now, I want to point out that I think that's the only study that's really looked at just statin myalgia. It's not a perfect study. Why is it not a perfect study? Well, unbeknownst to me, my wife volunteered and entered the study. Okay, I didn't have anything to do with that. You don't want to recruit family members into your studies. It's prohibited. But I actually didn't know she was doing it. Until one of the people in the study, one of my technicians say, hey, your wife is finishing up today in the study. And I said, what? She's in this. So she'd been in the study. Now, so later she said to me, when she was on a statin, she said, and she was on, we found out she was on a statin in the study, and she had recorded having no symptoms. But later she said to me that when she was on Crestor, she said, I think I'm getting cramps on this drug, just like I got in the study. And I said, wait a minute, you got cramps in our study? Then I looked back. We didn't ask about cramps. We asked about muscle discomfort. We did not specifically ask about cramps. And I don't know about you, but I think cramps are one of the more frequent symptoms of people on statins. So I think our study was probably the best done so far, but there's no perfect study. And I go back and say, oh, I'm so angry at myself that we never asked about whether they were having cramping. Now, I'll tell you another story. I've argued for years with the people at Oxford, wonderful group, great epidemiologists. They don't believe there's, at least for a long period, they didn't believe there was any muscle symptoms with statins. They didn't believe it. And I could tell you some stories about what they've said to me about that and their criticisms of our work, but I won't. Because it'd be beneath me. But now their more recent publications suggest that they think there may be 1% of people who do get muscle aching. I think the statin symptoms are real. They're not real for most people. Most people don't have real statin symptoms. They just kind of think they do. But I'm convinced that there are statin side effects, muscle side effects. It's quite low. So what is my approach? I told you about that we often use rosuvastatin twice a week. So I will often use twice a week rosuvastatin. And also I combine a lot of that with ezetimibe. Why do I use ezetimibe? Because ezetimibe will lower your cholesterol level between 20 and 24% alone. And I've told you about the statin rule of 6. Doubling the statin, increases the risk of side effects, but doesn't give you a whole lot of additional cholesterol reduction. So my approach with many patients differs from the guidelines. I frequently, especially people who've had trouble, if people have had trouble, I use low-dose statins in combination with ezetimibe, and you can get big reductions. For example, in our study using rosuvastatin, 5 milligrams Monday and Thursday, we got a 27% reduction in LDL. You throw in 10 of Zetia daily, which has a low risk of muscle issues, you get about a 50% reduction, 27%, 20%. You're close to a 50% reduction with very low doses of the drug. It's something that I do a lot.
Yes, and the lower doses of statin would have less, low doses of statin in comparison with higher doses of statin would have lower risk of myalgia?
Absolutely. It's a dose-related thing. I mean, all of you who practice preventive cardiology or just general medicine, you know that when you double the doses of statins or when you change the dose, you increase the dose of statins, you're much more likely to have somebody complain.
Do you find a specific statin that has higher risk for myalgia than other types of statin?
I haven't studied it extensively. Simvastatin has been given one of the one of the worst reputations because it seemed to cause a fair amount of rhabdomyolysis. Remember, there used to be an 80 milligram dose of simvastatin, but it kind of disappeared and down to 40. But beyond that, I'm not. I don't study it as much anymore.
You said in your study or practice, you used to give 2 days of statin, low dose of statin, rovastatin, and ezetimibe 5 days or 7 days?
So the point is that with the statins, especially rosuvastatin, we do a lot of Monday and Thursday. For some reason, clinically, I don't have a study on this, clinically, we find that atorvastatin works best given it 3 days a week. So we often give atorvastatin low dose Monday, Wednesday, Friday. Seems to work better. Rosuvastatin seems to last longer. Now, how much ezetimibe I'll give depends. If a person really doesn't want to take much medicine, I'll give ezetimibe Monday, Wednesday, Friday, because ezetimibe has a 14-hour half-life as well, so its effect will last. But generally, I use ezetimibe 10 milligrams daily with twice a week statin or 3 times a week statin. Now, remember, I run a clinic that sees patients with muscle complaints. So I do what I can to keep them on low doses. Now, why shouldn't everybody just get hammered? Why shouldn't the whole world just get hammered with 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin and get rid of atherosclerosis? Well, if you don't need to do it, remember, I think everybody pretty well agrees that statins do increase the risk of getting diabetes. So, and that was shown in the Jupiter trial. The Jupiter trial showed that there were about 2,000 people on rosuvastatin and in a placebo group, and you got 54 more cases of diabetes, but you got like 150 fewer heart attacks, et cetera. So the benefits clearly outweighed the risk. But that was a group that needed the statins. That's why the benefits outweighed the risk. If you give statins to people that aren't very risky, then you have the risk of the only thing you're doing is increasing the risk of diabetes. So I think all of these drugs, even though statins are great drugs and I use them all the time, I think you always have to make a judgment as to whether you're doing the patient a favor or not a favor. Jupiter found an increased risk of diabetes. Now, here's why I think Jupiter found an increased risk of diabetes, because they selected people with a CRP over 2, right? And CRP goes along with a bigger waist size. CRP goes along with more interleukin-6. I wonder if CRP isn't a marker of early insulin resistance. And so you selected people with high CRPs, my theory, early insulin resistance, you found more diabetes because these people were more vulnerable. Because you know what, the other studies haven't, there are a lot of other studies that haven't suggested an increased risk of diabetes. And I know a lot of the companies say, you know, their drug won't cause diabetes, but really you need to test it in a vulnerable population, a population that's likely to get diabetes.
How high does it increase the blood sugar in terms of A1C? Does it increase like by 1 point, 2 points, or does it increase it significantly?
It depends on who you are, because in the Jupiter trial, if you did not have risk factors for diabetes like body weight, you know, et cetera, if baseline high but not diabetes glucoses, if you did not have risk factors for diabetes, you didn't get diabetes. So what statins do to your risk of diabetes depends on what's your underlying risk of diabetes.
This is a bit of a controversial question, but what are your thoughts about aspirin in primary prevention? Someone who's above 50, let's say.
You know, it is a controversial question. So how do I deal with it? I deal with it on an individual patient basis. You know, I don't make public policy. I'm glad I don't make public policy. I like to use as little as possible. You look at most of the studies of aspirin, and aspirin was effective in reducing the risk of heart attacks, but aspirin increased the risk of bleeding. I don't know. I fear heart attacks much more than I fear the risk of bleeding. So if somebody is risky for heart disease, they have a high coronary artery calcification score, for example, they have a lot of risk factors, they have a terrible family history. I am tempted to use aspirin in those instances because now if they have a history of bleeding or they have ulcer disease or something, then I don't. But, you know, and then sometimes I will use aspirin 3 times a week rather than 81 milligrams 3 times a week than 7 times a week. But, you know, I actually take care of people rather than population, so it depends on the situation. The more worried I am about a person and their risk factors, the more likely I am to say to them, look, most of the studies and most of the recommendations now are that you don't use aspirin for primary prevention. I am concerned because you have such a terrible family history and your dad didn't smoke and he had a heart attack at a young age. I'm going to suggest you take aspirin. Let's do it just 3 times a week, et cetera.
Mm-hmm. And would you consider hypertension as a risk factor for the risk of brain hemorrhage?
But my understanding, the risk of hypertension is to increase the risk of heart disease. But the biggest risk of hypertension is you know, heart failure and stuff like that. So I'm less worried about hypertension as a reason to put them on aspirin than I am about a high lipoprotein A, which I almost always start them on aspirin, or other factors that make me think they're risky, diabetes, bad family history, et cetera.
What I meant is that with hypertension, they would have higher risk of brain hemorrhage, and aspirin would increase on top
Yeah.
of that risk. Would you be
So
concerned if they have hypertension?
I'm not so concerned, but I don't use hypertension alone as a reason to kind of go ahead and be more aggressive. And I think you make a great point. Something that I about not using it in that group because of that reason.
But you would hold it just because of hypertension?
I'm not greatly concerned about the risk of increasing brain hemorrhage. I mean, I always am, but I don't look at I don't use hypertension in my present status as a game changer as to whether I'm going to start aspirin or not. My thing with aspirin is I don't do it frequently. I do it in somebody that I think I'm concerned about, like a high coronary calcification score or something like that.
To ask you about colchicine, what are your thoughts on using it for chronic stable angina?
I don't do it routinely. I know the data is mixed. I'm not an expert. I have not done it routinely. I must admit, if I think someone has a gout risk, I might, but I don't do it routinely. I don't do everybody with, most of my patients argue about the number of medicines they're on anyway.
Do you have thoughts about exercising while fasting?
I think it's the most important thing is to exercise. It's very hard to exercise on a full stomach. I mean, I was actually I'm not heavy, but I was leaner when I ran competitively because I couldn't do hard workouts after eating. So I had to restrict some caloric intake somewhat, but no, I don't have thoughts about exercising when you're fasting. I think the concept is that because doing endurance exercise, you want to burn fat rather than skeletal muscle glycogen. So the idea to exercise when you're fasting is to train your body to break down and use free fatty acids. The same idea with being on a ketogenic diet. Does a ketogenic diet train you for exercise training? I've seen some of these things. It's not an area that I'm an expert in.
Is there any specific topic you think we did not cover, or an important area that you want to address and talk about?
So I think that we use a misnomer when we say borderline diabetes. And that's because when we measure diabetes, we measure it looking at glucose levels and hemoglobin A1C. So when we measure and diagnose diabetes, we do it on the basis of glucose. But glucose is deposited or cleared, not totally, but a lot by skeletal muscle. Fat cells are much more sensitive to insulin than skeletal muscle. And the first sign in many patients of insulin resistance is elevated triglyceride levels, because the triglycerides, free fatty acids, come out of your fat cell when your insulin levels are low. Those free fatty acids go to your liver, and the liver gets fatty, or they get made into triglycerides. Okay. I've seen over my lifetime so many patients sent to me with high triglycerides and not diabetes by any of the measures we could measure, but a borderline A1C. But over time, they became diabetes. The fat cell is more sensitive to insulin than the muscle cell. So even small decreases in insulin show up as a deranged fat metabolism, as elevated triglyceride levels. I can't remember his name, but there's a famous diabetologist who says that when you have borderline diabetes, you're already lost 50% of your insulin secreting capacity in the pancreas. So I think one of the biggest errors we make as internists, cardiologists, is this idea of a patient has borderline diabetes because their A1C is not abnormal. I actually wonder if a lot of the risk factors that we consider independent of diabetes are actually a marker of diabetes. For example, a low HDL. HDL goes down when you've got insulin resistance. A high CRP. CRP, goes up when you have increased waist circumference, which goes along with diabetes. So high triglycerides. So I think we need to be very careful as physicians with borderline diabetes. And we ought to be more aggressive about when somebody's got borderline diabetes, getting them to lose weight, getting them to exercise, maybe considering putting them on metformin. We all know about the diabetes prevention trial where they gave metformin, exercise, or placebo. And both the exercise weight loss and the metformin lowered the onset of diabetes. So my parting thing is, borderline diabetes isn't necessarily safe. It's a real risk factor for heart disease, I think.
You mentioned earlier that you were measuring in one of your studies the triglyceride continuously. Did they do it just as a normal test or through any special devices?
No, we didn't measure triglycerides continuously, but what we did way back in the 80s is we did a lot of studies on triglyceride clearance. So, for example, we would give intravenous intralipid. Intralipid was used to give people fat when they were in the intensive care units and couldn't eat. But I took a bunch of my distance running friends and we gave them intralipid intravenously before and after marathons to look at how quickly they got rid of fat in the blood. So we were not using continuous triglyceride monitoring. We were monitoring it for daily after long exercise sessions.
What are optimal levels of triglycerides?
Yeah, really, normal triglycerides are probably under 150. Doesn't mean that I go treating them, when they're in the 200, 250 region, but I do treat more aggressive with the LDL. The time you really get worried about triglycerides is when you have fasting values 800 or so, because those people can get life-threatening pancreatitis. If you have a fasting triglyceride that's that high, 800, I see those people immediately and put them on something to lower their triglycerides, often a fibric acid derivative in fish oil.
Some experts would want the triglyceride as low, below 100. Would you agree that the lower is better?
I think with most risk factors, lower is better. With blood pressure, lower is better. With glucose, lower is better. With body weight, to a point, lower is better. With triglycerides, lower is probably better. With LDL, clearly looks like lower is better. So most risk factors, lower is better.
Would you agree that to live longer and live a healthy life, a mix of cardio, strengthening, isometric, and mobility, combination of all of those would be the best approach?
I think the best evidence is for aerobic exercise for longevity. The best exercise for muscle strength and overall fitness is the weightlifting. And I think combination is great because variety is the spice of life. So if you want to be a fast marathon runner, you've got to train fast and you've got to train long. If you want to live for a long period of time, the data suggests that you've got to do modestly intense aerobic exercise, such as brisk walking. If you want to have good skeletal muscles to keep you out of the assisted living, then you should do some weight work for upper and lower body a couple times a week. So it all depends on your goals. I'm not a big recommender of intense exercise for heart disease prevention efforts. And the reason I'm not is that most people don't want to do it. They don't find it a lot of fun. Where I used to love running, quarter-mile intervals when I was I was a competitive distance runner. I used to love running half-mile intervals and mile intervals with my friends. That's very different than a person that's because we were trying to run fast races. That's very different from a person who's just trying to live longer. That person should go for a good brisk walk. We recommend every day. The 2018 American guidelines are 150 minutes a week. I don't think they've been updated.
Dr. Paul, it's been an honor to have this conversation with you. I have learned so much. Do you have any books or any social media or website that people can follow you and see more of your work?
Substack. The Substack, that's where I am. I'm on Substack, the blog on Substack.
Yeah, we will link that.
Yeah.
And do you have any book?
I've written a book in 2019 called Exercise and Sports Cardiology. So exercise and sports, I can show it to you. That's it. Exercise and sports cardiology.
And where can people find these books if they want to purchase them?
The World Scientific Exercise and Sports Cardiology. It's published by World Scientific. It seems like just yesterday, but it was actually published what year? I think it was 2019, 2017. My gosh, time flies.
Like I said, it's been an honor to speak to you, and thank you very much for
My,
coming to
my
this interview.
pleasure.
Okay, well,
Thank you
very
for
good.
having me.
Thank you.
Nice to meet you.
Nice to meet you as well. Thank you. Take